Hello, everyone, and welcome to another episode of Dr. Gilbert Hosts. Today, our broadcast is entitled Sleep Issues in Parkinson's Disease, and that will give us a chance to delve into some very troublesome symptoms that many people with Parkinson's deal with. And I mean by that difficulty falling asleep, difficulty staying asleep, vivid dreams, acting out dreams, sleepiness during the day, and more. And I know you're eager to hear what our expert says today. I would also like to take this opportunity to thank the sponsor of today's broadcast, which is the Simone Foundation. Thank you so much for your support. I'm very excited to introduce today's guest, who's Dr. Maria Ospina. Dr. Ospina is a movement disorders neurologist in private practice in Phoenix, Arizona. In addition to her abundant expertise in the real-life problems of people with PD, she's active in research, participating in NIH and pharmaceutical-sponsored clinical trials for PD. And she's been an investigator in the Parkinson Study Group and is often an invited speaker on a variety of topics related to movement disorders. Welcome, Dr. Ospina. We are so honored to have you here with us today. I know our audience is chomping at the bit to ask their questions, and we'd like you to kick it off with a brief presentation.
Great, thanks. Good morning, everybody here on the West Coast, and good afternoon for everybody in the East Coast. And so today we'll talk about sleep and Parkinson's disease. We'll have a few slides, and then go ahead and put your questions in the chat, and then we'll address them at the end of the slide deck. So, why is sleep so important in Parkinson's disease? And it's not important just in Parkinson's disease, but just in our life in general. Did you know that as mammals, we spend a third of our lives asleep, and that turns out to be 25 to 30 years out of our lifespan asleep. So something very important is happening during that time, and we'll go into that. And so, how is sleep impacted specifically in Parkinson's disease? So sleep disorders associated with Parkinson's disease, those are things like restless leg syndrome, REM sleep behavior disorder, sleep disorders that result from your Parkinson's medicines, like your dopamine agonists that cause excessive daytime sleepiness or sleep attack, and then common PD symptoms that impact sleep, such as rigidity, tremor, trouble with your bladder, frequency, nocturia, that keep you up at night, and then fatigue and excessive daytime sleepiness. So why is sleep so important in Parkinson's disease? And just in general, so it turns out that during sleep, that's when the body is doing all of its restorative work, not only for the body, but also for the brain. So if you sprain your ankle, that healing is taking part during your deep sleep. That's stage 3 and 4. The same thing happened during sleep during the brain, for the brain. So all the housekeeping that's happening for the brain is happening during sleep. So think of it like your car. When you change the oil in your car, you do that when the car is at rest in the garage. You don't do it while you're driving down the highway. So the same thing happens in the brain. So all that cleaning up of those misfolded protein, which Parkinson's disease has that alpha-synuclein that's misfolded and has to be cleared from the cell. And there's a problem with that in Parkinson's disease. That clearing of those misfolded proteins happens during deep sleep. Same thing with things like learning and memory. All of that is consolidated during stage 4 and stage 3 sleep. So when you learn something, whether it's a new piano piece or a new recipe, or even motor tasks like learning how to ski, those sorts of things, that only gets better after you sleep on it. That's sort of like why we sleep on, let me sleep on that. And those things all happen during sleep. So the housekeeping is happening during sleep. And so then what happens if we can't do any of that housekeeping? Then the next day is not that efficient. Patients with Parkinson's disease notice that their medicines don't work as well, and both their motor symptoms and non-motor symptoms are worse off. So there's more tremor, more rigidity, and just like you can have bradykinesia, which means slowness of movement, you can also have bradyphrenia, which means slowness of thinking, and you may notice that when patients aren't sleeping well. That leads to more napping during the day, and sometimes that napping can stretch into most of the day, and then you change your sleep-wake cycle, and so you're sleeping most of the day and then up at night, and that causes more problems. So next slide. Or how do we evaluate sleep in Parkinson's disease? So there's a sleep study, the fancy name for that is polysomnography. And what we look at there, we look at the brain waves or the EEG. So when you're going through the different stages of sleep, and when you're getting into REM sleep, which is your dream sleep, and then stage 3 and 4, which is your deep sleep, when that learning and memory is taking place. And then they evaluate your oxygen levels in the blood to make sure that you're not having apnea. What is your heart rate doing? What's your breathing rate doing? are your eye movements, so that's the REM sleep behavior disorder, and then your leg movements. Are you having restless legs or periodic leg movements in sleep? So what sleep disorders are common in Parkinson's disease? So by far the most common, and the one that we first encounter even before your first diagnosis of Parkinson's disease, is RBD, or REM sleep behavior disorder. We'll go into that a little bit later. And then there's insomnia, and you can have both primary and secondary. So it's trouble falling asleep and then trouble staying asleep. You can have sleep fragmentation, which is extremely common in Parkinson's disease. And one of the questions that we get a lot in the office, restless leg syndrome and sleep apnea. So let's talk about REM sleep behavior disorder. So remember, by the time you come and see the neurologist with your diagnosis of Parkinson's disease, you've already had what we call the premotor symptoms of PD for many years, sometimes 10 or 15 years before your motor symptoms of Parkinson's develop. Those are things like tremor, rigidity, bradykinesia, or slowness of movement, and trouble with gait and balance. So many patients will notice that they've had a history of constipation, they have a history of anosmia or losing their sense of smell, they may have a history of anxiety or depression, they could have restless leg syndromes, and then many patients have REM sleep behavior disorder. So they talk in their sleep. So what happens in that scenario is that usually when you go to sleep and when you go to REM sleep, which is your dream sleep, usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis no longer takes place and you're free to act out your dreams. So patients can talk in their sleep, they can yell in their sleep, they can kick and punch and move around in their sleep because they're acting out their dreams. And it turns out that REM sleep, the brain is using that to practice getting away from a threat. And that's why in both men and women, these dreams tend to be very violent. There's a lot of sort of running away from a threat and a lot of kicking and screaming. So that's normal. It's nothing to worry about. Usually the patient doesn't remember anything in the morning, and it's really a problem for the bed partner. That's the one who's being woken up with the screaming and getting punched and kicked at night. So many times that's present before the Parkinson's disease is diagnosed. And then how do we treat patients with RBD? So if you're, falling out of bed, many times we'll use a bed rail. If there's a lot of movements in some patients where they're hitting their head against the drywall, that sort of thing, sometimes we'll put you in a sleeping bag to confine the movements. Many times you'll find that your bed partner will build a pillow fort to protect themselves or sleep in a different bed or a different room. So we modify the environment that way, take the lamp farther away from the nightstand so you're not hitting it. We can use over-the-counter medicines like melatonin to suppress REM. And if we need to, we can use prescription medicines such as clonazepam that also suppresses REM. So RBD is extremely common in Parkinson's disease. It's violent dreams in both men and women. So it has nothing to do with your psychology or anything like that. We treat it with usually melatonin, clonazepam, and then modifying your environment at night. Many times we'll use things like a bed rail. So let's talk about insomnia. So insomnia is also very common in Parkinson's disease. So many times you can have trouble falling asleep. That's primary insomnia, or secondary insomnia, which means that you have trouble staying asleep. Staying asleep, that's very difficult in Parkinson's disease. Remember, in Parkinson's disease, there's low levels of dopamine, and we have to replace that dopamine with medication. During the day, you're taking multiple doses of your levodopa, and so you've got good levels of levodopa during the day, but then we stop taking medicine at night, and those levels of dopamine fall, and that could lead to sleep fragmentation. So as your levels of dopamine fall, then your motor symptoms can come back. You can have rigidity, stiffness, trouble turning in bed, getting in and out of bed. When you wake up, you have urinary urgency, or your bladder says, hey, you have to get up and go to the bathroom, and then it's difficult to fall asleep again. So we can treat that by adding more medicine. We'll talk a little bit about sleep fragmentation on the next slide. But we improve your sleep hygiene. So again, we want to make sure that you're not having multiple naps during the day, that you're sleeping most of the time during the day, and you've changed your sleep-wake cycle. We can use cognitive behavioral therapy to help you with primary insomnia. We review your medication. So many times patients are on medicines that keep you up, or they're using a lot of caffeine late in the day. Medicines such as selegiline caffeine. Remember, those are twice a day medicines, but we like you to take them in the morning and at noon, not morning and evening, because it has a metabolite that's similar to amphetamine. It can keep you up at night. So it's important. That's why it's important when you come into the office, we always want to know what medicines you're on, what is the name of the medicine, how many milligrams are you taking it, what time of day are you taking it, so we can figure out is there things like caffeine or things like selegiline or other medicines that keep you up at night. Again, for primary insomnia, we can use some melatonin, start at 3 milligrams, go up to 10 milligrams at night to help you fall asleep. And then we want to keep you asleep. Again, we can refer you to a sleep specialist. But again, always we want to treat the cause of the insomnia, not just put a Band-Aid on it and give you some Ambien or something like that. So let's talk about sleep fragmentation, which is extremely common in Parkinson's disease. And it's the most common reason why patients wake up multiple times during the day. So as we said, the normal brain gives you a continuous infusion of dopamine over the 24-hour period. But our medicines for PD are still oral medicines, pills that you take by mouth that end up in the stomach. And because you have gastroparesis or that slowed gut and you're constipated, those pills don't actually get absorbed until they get into the small intestine. And because we don't have a once-a-day levodopa, we're stuck taking levodopa multiple times a day, whether you take it as Sinemet or the extended release form as Rytary, but still it doesn't quite last the 24-hour period. So patients' motor symptoms can come back, such as the rigidity, the bradykinesia or slowness of movement, the trouble turning in bed, getting in and out of bed, and then those bladder symptoms. So what do we do with those patients? Many times we'll switch your medicines if they're available to once-a-day medicine. So once-a-day dopamine agonists so that you get coverage during the day and at night. We use once-a-day MAOB inhibitors or COMT inhibitors, and then we use the longest form of levodopa that we can get our hands on. So we can use Rytary, and in some patients with advanced disease, we can use Duopa or one of the levodopa pumps to give you a more continuous infusion of levodopa throughout the night and prevent as much of that sleep fragmentation due to those off periods that patients have during the day. So let's talk about restless leg syndrome, also very common in Parkinson's disease. So unlike RBD or REM sleep behavior disorder, that we know that most of those patients who have RBD in their 30s, 40s, and 50s are going to go on to develop an alpha-synucleinopathy like Parkinson's disease, most patients with restless legs are not going to develop Parkinson's disease, although most PD patients have restless leg syndrome. So just because you have restless leg syndrome in your 30s and 40s doesn't mean that you're at risk for a Parkinsonism. So there are many other reasons why you can have restless legs. You can have iron deficiency anemia, you can be on dialysis, have kidney disease, you could be pregnant. And what restless legs is, they have uncomfortable or weird sensation in the legs and sometimes in the arms as well. And you have to get up and walk around to make that feeling go away. It's very common in Parkinson's disease, and we can treat it quite well by using dopamine agonists. So those are medicines like pramipexole, ropinirole, and Nupro or the rotigotine patch. Many times, if you have symptoms not only in the evening, but also during the day, then we can use a once-a-day medicine. The patch works quite well if your symptoms start not in the evening, but they're starting earlier and earlier, like at lunchtime, then a once-a-day medicine works for that. Again, you can have neuropathy that can be a source of restless legs as well. So let's go on and talk about sleep apnea. So sleep apnea is also common in Parkinson's disease. There's a primary and secondary form of sleep apnea. Many of our PD patients, they're not heavyweight or obese, which is a common form of sleep apnea. Our PD patients tend to be quite skinny because they're always burning lots of calories with a tremor, the dyskinetic or involuntary movement. They have a central form of sleep apnea. And so we usually treat that. So we evaluate the patient with a sleep study, as we talked about before. And then if you're having a lot of apneic episodes where you're not breathing well, then we can use CPAP or BiPAP throughout the night. And we see this gentleman using a CPAP machine to help you keep that blood well oxygenated. And that way in the morning, you don't wake up with so much fatigue. You don't wake up with a morning headache. You're a little bit more refreshed during the day. Again, it's also important not only to treat the sleep apnea, not only from the point of view of fatigue, but it also puts you at risk for things like heart disease, stroke, cardiac arrest. And so we want to make sure that we prevent that as much as possible. Anybody who's not sleeping well, we know they're at risk for depression, poor memory, headaches. And remember, why do patients have poor memories? That your short-term memory consolidates into long-term memory during deep sleep. And if you're not getting good sleep, you're not getting that short-term memory turning into long-term memory. And that's the cause of that poor memory. So let's talk about sleep disorders that are specific to the medications that you take in Parkinson's disease. So remember, the medicines that you take for PD, they help the motor symptoms of Parkinson's disease. So they make your tremor better, they make your stiffness better, your gait and balance better, but they can make your non-motor symptoms of PD worse. So they can make you more sleepy, they can cause more confusion and or hallucinations. They can cause more vivid dreams. And so our goal is to get that balance just right, that we are on enough meds that you're mobile, but not so much that every time you stand up, you feel like you're dizzy and going to faint, and that you're having wild, crazy dreams, and that you're hallucinating at night. So many medicines, like the dopamine agonists that we talked about before, those are things like pramipexole or Mirapex, ropinirole or Requip or Nupro, or the rotigotine patch. They can cause excessive daytime sleepiness. They can have sleep attacks. So it's the reason why your neurologist will ask you, are you falling asleep at stop signs or stop lights? And then we reduce the medicine accordingly. And then we'll sort of see what mix of medicines that you're on. Again, because the medicines are purely symptomatic, we never want the side effects of the medicine to be worse than the actual disease. So it's always important. That's why it's important that you have a good list of medicines and that we can review it as you come in with this different side effects. So what are common symptoms that we see in Parkinson's disease that impact sleep? So your tremor. Remember we talked about the sleep fragmentation. So as your levels of dopamine are low, those motor symptoms can come back. And that can be things like tremor. So your tremor comes back and it wakes you up, and then you have to get up and go to the bathroom, and then you can't fall asleep again. Rigidity. So you have trouble turning in bed, getting in and out of bed. And then you have non-motor symptoms of Parkinson's. So remember, your off periods are not just motor symptoms. It's not just tremor and rigidity. Your off periods include both motor and non-motor symptoms. And many times it's the non-motor symptoms that happen first, so that you may notice that during the day, that before you have that tremor in the right hand, you can have some paresthesias or numbness or tingling, and that you may feel some anxiety, or what some patients call it the willies. Some patients have a panic attack before the motor symptoms of PD come back. So the same thing can happen at night. So you can have anxiety, depression. Patients who have untreated depression have trouble with sleep. Sometimes they sleep too much and sometimes they sleep too little bit. You can have hallucinations or sundowning that keeps people from falling asleep at night and causes a lot of agitation as the sun is going down and more confusion. You can have pain from dystonia or Parkinson's, the off period. So dystonia means an abnormal contraction of a muscle. Many times first thing in the morning, you'll notice that your foot is turned in, that big toe goes up and the other toes curl under. And that is called dystonia, and that dystonia can happen in any muscle in the body. In Parkinson's disease, it's most common in the foot, sometimes in the neck, but it can be anywhere. And some patients have abdominal dystonia. They end up seeing the GI doctor and the OBGYN, and it's basically an off period. Those muscles are tight and rigid and can be quite painful. And again, we always want to treat the cause of the symptom. So if you are having pain from an off period, the treatment for that is to improve your dopamine levels, not to give you just pain medicines and cover it up. The same thing with insomnia. If you're having sleep fragmentation and that's causing your secondary insomnia, we want to treat the cause of it by adding more dopamine instead of just giving you a sleeping aid and sort of putting a Band-Aid on it. And then urinary symptoms are extremely common in Parkinson's disease. They're part of the non-motor symptoms of PD, and patients can have frequency. They can have nocturia, where they go multiple times at night. They can have urgency. So as soon as you wake up, you just, you don't have 2 minutes to respond, to run into the bathroom. And so we can use medicines like Vesicare, Miberic, those sorts of things, Flomax. And then it's also important in advanced disease that we protect you from falls, especially at night. And so that, patients are quite resistant having a bedside urinal or a bedside commode. So if it keeps you from having to get up and walk and have freezing of gait at the doorway and fall at 3 o'clock in the morning, it's better to do that for those bladder symptoms if the medicines don't work. And then next slide. So causes of fatigue and excessive daytime sleepiness. So fatigue is extremely common in Parkinson's disease. It's present many times before your diagnosis of Parkinson's disease. And many times it can improve a little bit with adding the medicine. So remember, your dopamine, whether you're getting it as Sinemet or Rytary, that levodopa is like gas in the car. So as we add in more gas in the car, that fatigue should get better. But during those off periods, the fatigue is going to come back. Remember, you can have excessive daytime sleepiness is a side effect of your medicines. Usually those are dopamine agonists that we talked about before. And then as neurologists, we always tend to look at everything through our Parkinson's eyeglasses, but it's really important that we don't always dismiss everything and just blame it on PD. So there can be many other reasons why you have constipation, like, colon cancer. It's important that you keep up with your regular medical workup and get your colonoscopies every 5 years. So you can have fatigue because you have low levels of B12. Your thyroid isn't working well. You may have an anemia that's gone undiagnosed. So always it's important to rule everything else out before we blame it on Parkinson's disease. As we talked about depression, patients with depression can have anhedonia, can have trouble getting out of bed, doing activities that they like to do. So they either sleep too much or too little. And again, Parkinson's is a progressive disease of the brain. There's neurodegeneration in that brainstem, and that can be have trouble with maintaining good sleep. And next slide. And then strategies to improve your wakefulness during the day. So always activity is very important. Exercise is super important. Remember that those medicines for PD are purely symptomatic and they only help the motor symptoms of PD. And it turns out that exercise not only helps your motor symptoms of PD, like tremor and rigidity and stiffness and gait and balance, but it helps your non-motor symptoms of PD. And part of that is it helps you with sleep, it helps with insomnia, it helps cognition, it improves mood. So exercise does more for you than any pill we can give you. And we don't have to get prior auths from your insurance company from it. Some patients can use light therapy, so to sort of reset your circadian rhythm and also help with, patients who live up north, they have seasonal affective disorder that can change your sleep patterns. And then we can use medications, which we don't like to use medicines as a Band-Aid. We want to definitely just figure out what the cause of the sleep problem is. Do you have restless legs? We treat that with a dopamine agonist. Is it RBD? We can use that. We can use melatonin or clonazepam, that we just don't put sleep aids on there and just put a Band-Aid over it, that we treat the cause of the primary problem with sleep. So any questions that you guys have, we can go into that now.
Thank you so much, Dr. Ospina. That was a treasure trove of very important information, and our audience has been commenting wildly in the chat, so we're ready to take our audience questions. And we have a number of questions that were submitted to us to start off today's conversation. We have a lot of questions that have been submitted as Dr. Ospina spoke, and if you still have a question, and I'm sure you do, please submit it now, and we will get to as many as we possibly can. Now, in order to submit your question, you'll need to be logged into YouTube or Facebook, and again, we may display your question along with your name and your photo that you're logged in with. So please be aware of that. So let's get started. We have a great question from Karen. Now, you addressed this a bit at the end, but I know this is a question that comes up again and again. So I'd love to spend a little bit more time on it. And that is, my husband has had PD for many years. He sleeps fairly well at night, but he sleeps a lot during the day. How do we get him to not sleep so much during the day?
Yeah, and remember that all of your PD medicines cause sleepiness. So whether it's your levodopa or your dopamine agonist, so every time you take a dose of your medicine, you're going to get sleepy. And it's okay to take a little 20-minute nap. What you don't want is that 20-minute nap to turn into a 2 or 3 hour nap multiple times a day. And then you're sleeping most of the day and then up at night. And so we want to keep you active during the day. So we want to do activities during the day. We want to enroll you in things like rock steady boxing, something that engages the brain. Because if you just sit in front of the TV, you're just going to fall asleep, especially if you took a medicine that makes you sleepy. So we want to engage the brain and keep you active as much as possible. So that's why it's so important for patients to go to things like neural wellness centers, their physical therapy classes, their rock steady classes, something for them to look forward to and keep them engaged, because those medicines make you super sleepy. It's another reason why your doctor, let's say you're taking a dopamine agonist 3 times a day, they may switch it to once at night so that the side effects of that sleepy medication are just happening at bedtime and not throughout the day. The same thing, they can switch you to longer acting forms of levodopa so that you're not taking levodopa every 2 or 3 hours and getting sleepy with each dose.
Great. Thank you. Those are great suggestions. We have another question, which I know is on lots of people's minds, and would love to have you address this now, which is my father, there's a question from Jarl. My father has had PD for 10 years, has had much improvement in his sleep by taking CBD. What is your professional opinion of using CBD for sleep in Parkinson's?
Yeah, so there's not a lot of data on things like CBD and THC in Parkinson's disease. So we know that sedatives, remember that Parkinson's disease is the poster child for the mind-body connection. So everything that affects you affects your Parkinson's disease. So anything that's a sedative is going to quiet both the mind and the body and quiet the tremor. Not that it treats this tremor specifically the way levodopa does. We know that many patients use CBD at night to help with primary insomnia, and that seems to help them, but there isn't a lot of data behind it. It says this works specifically in Parkinson's disease. Always with any medicine or therapy, we want to make sure that the benefits outweigh the side effects. We like patients to use CBD rather than the form of THC, because the THC can cause hallucinations. And remember that the medicines you're already on are very psychoactive. So your levodopa, your dopamine agonist, can also cause hallucinations, can also cause confusion. And we want to be careful adding more medicines that can cause hallucinations. So, we say we can, in our clinic, when in Arizona it became legal, the whole clinic tried it. Initially, you needed a special card that cost $120. After the first year, most people didn't renew the card. They were just on their clonazepam. So most patients say, well, it helps with my primary insomnia, sort of falling asleep, but not really any of my other Parkinson's symptoms. So we'll see as more data comes out and more studies are done with marijuana, whether it's CBD or THC, if there's any other benefits. But always want to be careful. Do the benefits of the medicine outweigh the side effects of the medicine, including to your pocketbook?
Great. Thank you very much. I just want to address a question that came up in the comments, which is, what is an off period? So we've been referencing that term. Just wanted to define it for everyone. An off period is a period during the day when the medications that you would normally take for Parkinson's, their effects begin to wane. And so there is a return of your Parkinson's symptoms. And many people, not everyone, but many people, as Parkinson's disease progresses, experiences these periods of the day where their medications are working well. And as the medication efficacy starts to wear off, they begin to experience a return of their symptoms, and that's called an off period. And so what Dr. Ospina was saying is that at night, sometimes when you're not well medicated from your medications during the day and you haven't been taking medicine, you may be experiencing some of those off periods and off symptoms. So thank you, Christine, for pointing that out, that we needed to define that for people.
Yeah. So so let's sort of go into, and on and off. Remember that your off is just not your motor symptoms of PD. It's just not tremor and rigidity. Your non-motor symptoms of Parkinson's come back, and many times they come back earlier or first before your motor symptoms. So before that tremor comes out, you might feel some numbness or tingling in the hand or the foot. You can have some anxiety. And just like you can have bradykinesia, which means slowness of movement, you can have bradyphrenia, which means slowness of thinking. And many times it's the caregiver that notices, hey, the medicines aren't working because the patient is having trouble answering my questions, assimilating the questions. And let's go through the different kinds of off that you can have. So you can have end of dose wearing off. It's the most common reason why your doctor will change your medicines, so that you notice that your medicines that used to use last 4 to 5 hours now are only lasting 3 to 4 hours or 2 to 3 hours. And it's the reason why your doctor goes from taking the medicine 3 times a day to 4 times a day or adding more medicine, is because we need to replace that dopamine earlier. You're no longer able to buffer it or use it later on. You can have morning off, where during the day you're taking medicines throughout the day and everything seems to be working well. And then at night you're not taking any medicines, and then you wake up off, and it takes a long time for that first dose of medicine to kick in. So that's called morning off. You can have delayed on, so that you take your pill and you say, gosh, it used to work in 30 or 40 minutes. Now I notice that my pill takes an hour or 2 hours to kick in. And that's because, it's taking a long time to transition from the stomach into the small intestine. So remember, you can have bradykinesia, which means slowness of movement. That involves all of the muscles of the body, including the muscles of the gut. It's the reason why PD patients have constipation. So as the food and everything moves through the gut, more fluid gets sucked out of the stool gets hard, and you get constipated. And then that gastric colic reflex doesn't work, and stuff gets stuck in the stomach and takes longer to go into the small intestine where it's actually getting absorbed. So you notice that as a delayed on. And then your last off is unpredictable off. So that, remember, your levodopa, it's like gas in the car. So if you're driving your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. So that way you notice that some days your medicine lasts longer than others. So if you went to Rock Steady Boxing, you went to your exercise class, or you had a very emotional, stressful day, those medicines aren't lasting as long as they used to as a day that you're just sort of sitting at home watching Netflix, because you're burning through that levodopa faster. So you can have unpredictable offs. And it's one of the reasons why we'll use these on-demand therapies to help you through the dose between your doses of levodopa, to get you through that period where you did a lot of either physical or emotional stress to the body.
Fantastic. Thank you so much for that review of off. I'm sure many people experience much of what you described. So thank you for that. Darlene asks a question. She is curious about the medication Prozac. Is that going to affect your sleep? Is it better to take it at morning or at lunch rather than at night?
So Prozac is an antidepressant. So it's an SSRI. It sort of inhibits serotonin uptake. And so remember that depression is part of the non-motor symptoms of PD that's present many times years before your diagnosis of Parkinson's disease. And it's important to treat the depression. So it doesn't help if we've treated the tremor and the rigidity, but you're still so depressed you don't want to get out of bed. We haven't really improved your quality of life. So it's important to treat the depression. And again, always we want to make sure that the benefits of the medicine outweigh the side effects of the medicine. If you feel that it's keeping you up at night, it's a once a day medicine, you can just move it to the morning, or you can switch it to a different kind of antidepressant that you have less side effects from. So one, it's important to treat the depression, but then there's so many different antidepressants. You want to make sure that you get the one that's the right fit for you. So remember, just because the shoe is a size 8, you have to try it on and make sure it's comfortable for you. It's the same thing with the SSRIs, the antidepressant. Sometimes Prozac works really well for some patients. Sometimes they need other medicines like Wellbutrin or venlafaxine, or just a different other SSRI like Lexapro or Celexa.
Excellent. Thank you very much. We have a great question from Elias, who asks, will DBS, that is deep brain stimulation, help insomnia and sleep fragmentation? And just briefly, if anyone doesn't know on the call, deep brain stimulation is a surgical technique, a surgical procedure that is done for people with Parkinson's and other types of movement disorders as well, where a wire is placed deep in the brain and then tunneled under the skin and attached to a battery pack at the chest. And it is a different approach to treatment of Parkinson's disease. And Elias is asking, will such a treatment, which helps the motor symptoms primarily of Parkinson's disease, can that be used to help insomnia and sleep fragmentation?
So we said, yeah, so DBS is an electrical therapy for Parkinson's. As you remember, the brain talks to itself both chemically, and that's why we use medicines like levodopa, and then electrically, and that's why DBS works. So with DBS, we only promise your motor symptoms. So DBS helps dial out your tremor. So if you have a tremor that's refractory to medication, or we have to use such high doses of medicines that you're having hallucinations, then we know that we can dial out that tremor with DBS. If you have on time with dyskinesia or on time with involuntary movements or extra movements, then we know that we can dial those out with DBS so that you can have on time without dyskinesia. And those are the two main things that we promise patients with DBS. Everything else that you get is sort of frosting on the cake. So we know that patients, and then there's two different areas in the brain where we can put that stimulator in Parkinson's disease. One is called the STN and the other one's called the GPI. We know in patients where we put it in the STN, if we do it early enough in their disease course, we can lower their medication burden for a couple of years, and then they go up to the same sort of amount of levodopa. But if you get better sleep, which many patients do get improved sleep, we can never promise you that as sort of a primary benefit of Parkinson's of DBS. So basically, your benefits of DBS will be tremor control and on time without dyskinesia. But many patients do notice some, but it's not going to cure your insomnia. But that sleep fragmentation is a little bit less severe because your troughs, your off period, are not as deep as if somebody who didn't have DBS.
Fantastic. Thank you so much. We have a question that's actually been repeated a couple of times, so I know that's on people's minds, and that is the issue of cramping, leg and foot cramping at night. That could be dystonia, may not be, it may be a different form of cramping. Phyllis asks, I wake up frequently with leg and foot cramps / dystonia, but I can't find any correlation with exercise, taking magnesium, taking alcohol. Any ideas?
So always, the reason why your doctor wants to know what times you're taking the medicine is that so we can correlate whether your dyskinetic movements or your dystonic movements are related to your medicine. So one of the most common reasons for dystonia or an abnormal contraction of a muscle, which can be cramping in the foot, which is common in Parkinson's disease, is off period, so that your medicine has run out and sort of your gas gauge, your toe goes up and the other toes curl under, and then your foot turns in, and that's sort of your gas gauge saying, hey, I've run out of medicine. So if we can correlate that to when you take your medicines, then it's an easy fix, because we can just add more medicine or change your medicine around to fix the dystonia. So that would be if you have Parkinson's disease, that would be the number one thing we would be looking at. And then, we do some blood work, make sure that your electrolytes are fine, that you're not having either low levels of potassium, magnesium, that sort of thing. But in Parkinson's disease, usually the dystonia is from an off period, although you can also have peak dose dystonia, just like you can have peak dose dyskinesia or diphasic dyskinesia, too little or too much.
Thank you so much for that. We have a question from Melvin. He asks, is it okay to take NyQuil at bedtime as a treatment for insomnia? And if he takes melatonin, how much melatonin should I take at bedtime?
So again, we want to stay away things that like from NyQuil and Benadryl if we can, because we want to treat the cause of your insomnia, whether it's primary or secondary. What's the reason why you're not able to fall asleep, and then treat that as the reason. Are you having restless legs that are keeping you from falling asleep? Are you having sundowning, which is keeping you agitated and falling asleep? Are you having ruminating thoughts that don't allow you to fall asleep? So we would treat that first, and then before we would add things like NyQuil or Benadryl or melatonin. Our preference is melatonin. It seems to be better tolerated in PD medicines, and you start at a low dose, like 3 milligrams, and then gradually go up from there. But first, we want to treat what is the cause of the primary insomnia. So if it's restless legs, then that's very easily treated with dopamine agonist that you can take at night.
Great. We actually have a restless leg syndrome question from Desmond. Is numbness in the feet, could that be associated with restless leg syndrome, or is that potentially something else?
So numbness in the feet could be neuropathy, and neuropathy can be associated with restless legs. So again, always, remember we said that we don't want to always look at everything through our Parkinson's eyeglasses. We want to make sure that we rule out other things. Is the patient diabetic? Do they have neuropathy from diabetes? Do they have low levels of B12? Is that another reason for numbness in the feet or neuropathy. And then if we've ruled everything else out and patient has restless legs, then we can treat that. And then restless legs has, anywhere from like feeling weird, numbness, patients just have this, it's very difficult to describe, but what they do know is that as soon as they get up and walk around, that weird feeling gets better. And not only is it in the feet, but it can also involve the hands. And it not only is it at night, but it can get earlier and earlier during the day. And that's when we would use a once-a-day medicine, a once-a-day dopamine agonist to have better treatment of your restless legs. But again, we would want to rule out other causes of numbness in the feet.
Great. Thank you so much for that. We are actually getting toward the end of our broadcast. It's amazing. There've been an incredible number of questions, and I do apologize that we're definitely not going to get to all the questions that have been asked. So thanks again for submitting them. And we're going to ask one last question. Maybe we'll get one additional one in. Can you get accustomed to sleep medications whereby the medication is no longer effective?
So yeah, it depends on which sleep medicines you use. And again, that's why we want to treat the cause of the primary sleep problem rather than putting a Band-Aid on it and just giving you a sleeping aid. So as we said, what is the cause of the insomnia, or what is the cause of why you waking up in the middle of the night? Is it your bladder that wakes you up? Is it a tremor that wakes you up? Are you running out of medicine? And so do you need more medicine during the day? Do we need to add a longer acting form of levodopa or a 24-hour medicine so that you're not taking higher and higher doses of Ambien and Lunesta and these other medicines, or clonazepam? So you can certainly get used to those medicines and need a higher dose of your benzodiazepines to get the same job done that was done before. So again, it's always better to treat the cause than to just put a Band-Aid over it.
Okay, here's going to be our very last question, which is, what should I do if I'm wide awake in the middle of the night? Should I try to be active and get something done? Should I try to stay in bed? It can be so frustrating.
Right. Yeah. So that's certainly very frustrating. So the best thing to do is, if you get up and then you can't fall asleep, then do something else. Listen to a podcast, read a little bit out of a book. You want to read a real book, not an ebook, because that blue light keeps you up at night. And then you'll notice that after an hour or so, then you might get sleepy again and you can fall asleep again. Remember, you don't have to get all of your 8 hours at one go at night. So you can get a couple of hours and then be up for an hour or so and then get another couple of hours. But the thing is not to frustrate yourself as trying to stay in bed. So get out of bed, go sit in a chair, listen to a podcast, read a book, do something, and then go back to sleep.
Fantastic. Well, on that note, we're going to thank you so much, Dr. Ospina, for such wonderful information. I want to thank everyone for participating in today's discussion, for asking your questions, for submitting your comments. We really very much appreciate your active and live participation. And if you know someone who missed today's program, if you joined late, if you would like to watch this again, this recording will be available later today on our YouTube channel. And don't forget to subscribe to APDA's YouTube channel to watch new videos and live broadcasts. Now, remember, APDA can help connect you to the resources that you need. So call us at 1-800-223-2732. Visit us on our website, apdaparkinson.org, and we can help you in many, many ways. So please explore those options. I want to just inform everybody that our next episode of Dr. Gilbert Host will be on Wednesday, September 7th, 3 p.m. Eastern Standard Time. I'll be hosting Dr. Jory Fleischer on the topic of palliative care in Parkinson's. So be sure to join us for that important broadcast. Finally, be sure to stick around for a few final messages. Before I go, I want to thank you once again for joining us today. We hope to see you very soon on another APDA program. Have a great day.
Hi, I'm Leslie Chambers, the President and CEO of the American Parkinson Disease Association. Each month, across the country, APDA is providing support groups, exercise classes, and educational programs like this one to support the Parkinson's disease community. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. If you enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Your gift can help APDA support people living with PD through local programs, reliable resources, and groundbreaking research designed to find treatments and ultimately the cure for Parkinson's disease. Please donate today at apdaparkinson.org/donate. And thank you so much for your support.